Welcome to Early Evidence, a podcast series by the Moving Minds Alliance, where we bring you insights from researchers working at the intersection of early childhood development and emergencies. I'm your host, Dulguun, an expert advisor to the Moving Minds Alliance, and in today's episode, I'm joined by Dr. Dickson and Dr. Rosa Mendizabal-Espinosa from the University College London. We'll explore their research on mental health, well-being, and the lived experiences of children and families affected by crisis.
Thank you so much for inviting us to talk about this. We love to get invitations like this, so we really appreciate it. So my name's Dr. Kelly Dickson, an associate professor in global health and well-being at UCL. And my work more recently has focused on mental health and psychosocial support, or MHPSS, in humanitarian and fragile settings, and really looking at how systems respond to the mental health needs of children, young people, and their caregivers and parents, particularly in crisis-affected contexts, so humanitarian contexts like war and also natural disasters. So I started doing this work in 2015. So what drew me to it was often seeing how mental health could often be like a secondary thought, or it's siloed as separate or an afterthought. That has changed now in the last 10 years, definitely seen that mental health is more centered in those contexts. And so that's why I'm also drawn to it, because we really need to understand how complex interventions like MHPSS, which can cover a broad range of different types of interventions, how they work in different settings, and also how to be mindful of not causing harm or unintended consequences. So that's kind of my passion for sort of producing evidence synthesis in this area.
Thank you as well. My name is Rosa Mendizabal. I am a senior research associate at the Social Research Institute in University College London, UCL. I'm Mexican, and that's one of the reasons for conducting research in Mexico. I'm very passionate about understanding the context. Part of my research looks at how mental health and caregiving are shaped by health systems, and especially in under-resourced or crisis contexts. And I first became interested in newborn health and nurturing care during my doctoral research in Mexico, where I spent time in neonatal units trying to understand how the healthcare system was organized to care for very sick, very preterm babies. And I spent a lot of time seeing how families struggle to care for their babies in difficult conditions, like scarcity of resources, for example. So that sparked my commitment to continuing to study nurturing care practices in neonatal settings in the underserved communities. And during the COVID-19 pandemic, I was invited to participate in a study that was led by a university in Mexico, Universidad Panamericana, led by Dr. Vania Aldrete. And the study looked at the impact of the virus during the COVID-19 pandemic during pregnancy. So what happened to babies if they were exposed to the virus at the end of pregnancy? We worked together, Dr. Vania Aldrete, Dr. María Eugenia Gómez from Universidad Nacional Autónoma de México, UNAM, and myself, to try to understand more about how can we look at this not only from a biological developmental perspective, but a more holistic view of how exposure to the virus affects babies and families. And we looked at the emotional experiences of mothers and how the care of their babies was affected during this time of crisis and stress. And I'm sure I'm going to be talking a lot about the results of that project with you. But more recently, I've also been researching neonatal care for families in Mexico when they have to travel from rural or remote communities and have to come into hospitals in cities. And we're focusing on what helps or hinders nurturing care in those settings. So across all the projects, the focus has been on understanding caregiving as a deeply relational practice that needs to be supported, especially during emergencies or when the healthcare systems are fragile.
Thank you so much for the introduction. Yeah.
Yeah, just to add to that, so as a psychotherapist, that's also what drew me to work with Rosa on this, because often I work with adults when the attachment and that nurturing care may have been disrupted. So bringing in that kind of attachment lens and thinking about the interactions between children and their caregivers in those critical situations, and then also how the health system then responds and contributes or disrupts that as well. So.
That's very important. And yeah, it's definitely very useful to learn about your journeys, also coming to this specific topic when it comes to, how important mental health is, even if it was not really prioritized beforehand, and it's doing more so, but we still definitely need more attention to it. While, conducting your research work, especially mostly recently, what were some, realizations that were probably more striking and unexpected to you, especially when it comes to overall, as Dr. Dickson was mentioning about her also focus on how caregiver mental health affects their relationship with children, and overall how that at the end of the day also shapes the well-being of children themselves, especially in emergency settings. We're very curious to know about that.
Shall I go ahead first, or do you want to go ahead first, Kelly?
No, go for it, Rosa, go for it.
So particularly in the Mexican context and the study of the pandemic and how the COVID-19 pandemic affected the care of babies, we interviewed a lot of women, 37 women in Mexico City whose babies ate in hospital alongside them because they had been affected. Not the babies, but the women had been affected. And the most striking thing about this study, how was profoundly the pandemic disrupted the relational foundations of infant care. So if we think about what happened at the beginning of life, and we are talking about healthy babies who were born to mothers who had been infected with SARS-CoV-2, how we know the COVID virus. When a healthy baby is born, usually this connection, particularly with the mother, but with a wider context, is really important. In the case of these families, in the name of protecting newborns from infection, so in order to protect them not to get infected, hospital implemented measures, and of course under very difficult circumstances, because nobody understood about the risky infections for newborns at the time. But the measures like mother-infant separation, restriction from breastfeeding, or extended use from personal protective equipment, which extended days and weeks well into after discharge. And although these practices were well-intentioned, they had unintended consequences. They undermined the early bonding, the emotional closeness, and the responsive caregiving. So I wouldn't say it's striking, because in the area of work that I do, it's not unusual to see that babies are treated as medically vulnerable. But I do want to talk about this because I really believe we need to understand why we continue to exclude babies from the social and emotional care that is crucial to their development, and that we don't do as much in later stages of life. So one that children are more vocal, we don't tend to separate them from their parents unless it is strictly necessary. Of course, we did, or medical professionals and policymakers did not know what was best at that time. But I think that our study challenges the idea that protecting babies is only about managing medical risk. And it shows that emotional security, relational continuity, and the right to be close to their family are just as vital. And this is particularly special in emergency and crisis. So we call for a shift in how we design health responses from a more narrow focus on survival to a broader commitment to infant well-being and relational rights from the very start in life. Probably another finding that is really important to mention is how resilient mothers were and how they still found ways to connect to their babies after these very long periods of separation, and how family support was crucial to that.
That's very insightful information. Yeah. I want to second that. So where Rosa's conducting primary research and I'm looking at multiple primary research as part of a systematic review to synthesize that evidence, I'd say that often the findings aren't striking, they're actually very consistent, and the same issues come up again and again. When you're looking at interventions or you're looking at children and young people's experiences, their vulnerability is being prioritized over their agency and their resilience. And sometimes this is young people who have navigated war, migration, so many factors, and you bring in a mental health and psychosocial intervention from the global north, adapt it a little bit, and it doesn't fit, okay, because they weren't involved in the design. They weren't involved in thinking about what the goal is that they want. And then you have other findings around mental health, around stigma, comes up again and again in different contexts. The importance of the relationship, whether that is the relationship between the person delivering the mental health intervention or the relationships between people who are receiving the intervention, and whether or not, people even like this intervention. You're being told, okay, this is what you're going to receive. How are you experiencing that? What is happening to you? And thinking about whether, again, as I said before, whether or not that is having a detrimental effect, not having the effect that you may think it is. So, to be honest, I think what can be more striking is the fact that those findings are not, the evidence is there, but the findings aren't being implemented, whether that's due to resource constraints or other things. So I think that's kind of where we're coming from.
That's, I think, a very important insight, and brings me to the question also. I think both of you mentioned that the opinion and the needs of the caregivers themselves and the children were not necessarily reflected first-hand responses when it comes to the emergency settings and such. So ideally, in a perfect world, let's say, what will be the approach to really make sure to embed their voices and their needs first hand, so that we can actually design a much better system to help and to also prioritize mental health for children and their caregivers in emergency settings?
Well, I can mention an example of something that we are doing at the moment. So in 2023, Kelly and I and another one of our colleagues of the Batmunkh got a little bit of funding from our university to travel to Mexico and set up a multidisciplinary group to try and look at the Mexican context and the nurturing care provision and implementation and improvement of alongside the practitioners, the policymakers, and the people with the lived experience, the parents themselves. We held an initial meeting with a group of academics from universities there, non-for-profit organizations, healthcare practitioners, and other stakeholders. And we identified a group of parents, so associations of parents who wanted to participate also in these conversations. So that's how we started a network that is called the Neonatal Wellbeing Network, a collaboration between Mexico and the UK. And we try to share knowledge, experiences, and reflections. So we work in a horizontal way, and we really value everyone's knowledge, everyone's experiences, no matter where sector they are coming from, or if it is from lived experience, which in my opinion is the most valuable experiences that we have in the group. And we work together to identify, design, implement, or evaluate best practices in Mexico. And at the moment, we have a research project where we co-designed the study from the beginning with the clinicians, the parents' organizations, other local academics, and ourselves. And I think what was really important from that initial work that we did in Mexico is that we all came together to understand how primary research, but also the evidence synthesis part, which is where Kelly worked, can talk to each other and how one informs the other. So we started by trying to create a systems map, trying to understand all the institutions that or organizations that provide nurturing care or are involved in nurturing care, somehow who the users are, where the policies state, and then how we can bring together findings from previous research and mapping of policies, and to conduct further primary research.
Indeed, Dr. Dickson.
Yeah, I think research in this area and all areas is not just an academic pursuit. You really need to build that evidence ecosystem from the ground up, and you need that funding for that sustainable relationship. So you absolutely need collaboration between researchers, the policymakers, practitioners, and people with lived experience, to generate questions and generate data that really answers the questions, that people are facing in those local contexts. And that's often where the primary research comes in, and then being able to place that within the wider context of global knowledge and evidence synthesis. So yeah, it really takes skills and time and, kind of the values and the ethos for that kind of collaborative work. Yeah.
And if I may follow up on that point, I think that is also greatly leading us to our next question. Where were some insights that worked well when it comes to collaborating with all these different stakeholders, policymakers, funders, people working on the ground, but also caregivers and children themselves. So looking at, of course, I guess it's very context dependent, but regardless, what is the approach that you found helpful when it comes to having a collaborative environment when it comes to cooperating with all these various stakeholders together while doing your research?
So I think the very first thing I would say is understanding that developing these connections takes time. So this didn't just happen there and then. So we started this group from 2023, but it also goes back to previous connections and work. So I think we need to allow time to develop those connections with the community in general, whether they are academic, policymakers, people with lived experience. The second one is to make it as accessible as possible, and we are still understanding how we can do this. So we have weekly meetings, for example, with our research team. We don't call it research team; it's the co-production team. So I think just the wording changes a little bit how we approach the meetings. We try to make the meetings as accessible as possible, but that has meant that we need to provide further training for certain members of our co-production team. So the third thing probably is to understand how they are going to benefit from our project now and today, and not only in the future, because developing the research design, which we build together, and then starting the research and conducting the research takes time, and then to get to our findings and impact or implementation or dissemination of our findings takes time. So something that we also did from the beginning was to sit down and understand what are each one of us getting from this project, and where would people with lived experience want to work more on or contribute more towards, to what phases of the project. And we do have funding for people with lived experience to give back for the time that they use for working with us on the project.
Yeah, and I think from doing that extended collaboration work, and we've done like autoethnographies of the evidence ecosystem as well, and thinking about the kind of what the institutional mechanisms are that enable that relationship between the people who are producing knowledge and the people who are using knowledge. Really we're looking at that in over the long term. And again, with this project, also helps us to understand, okay, if you need evidence quickly, or you need a policymaker needs answer quickly, but you only have 3 months, or you only have a short time, what can you do? Okay, so it's not always about saying, yes, we are emphasizing the sustainability of these relationships, because we want to say, it's not something that you can necessarily do you would necessarily want to do in a kind of short way, because you don't want it to be tokenistic. But I think over time we're learning about how to have that meaningful collaboration where you can get insight from people in a quicker way. So I think that the core of it is knowing that kind of as a researcher, you are always going to benefit from talking to people who are living that, whether that's through the policy practitioners or the lived experience. You will get something, and your research will be more meaningful and more useful. So I think the first thing is really is having that value of wanting to do research that people can relate to and say, actually, this speaks to my context, and I feel like that I can use this in a way to help me think about the types of approaches, policy, health system changes that we want to make.
We try to remind ourselves that babies are at the core of our research, and that we don't take them as objects of our research, but as subjects, social actors who have the capacity to engage and contribute to these relationships. And that's one of the reasons for doing the research that we do. Thinking about how can care be improved so that babies are able to contribute, or given the opportunity to contribute to these relationships, even at the beginning of life, even in an emergency situation, and even if they are sick in hospital.
Yeah, those are very important points, especially given the fact that, that you mentioned how to prioritize children, babies, really at the forefront, rather than just consider them as some sort of thing that you're observing and researching about. Which leads me to the next question, which is actually around more about what are some. It's hard to find, I think, a very universal answer to this, but based on your research that you've been conducting in Mexico, but also beyond, when it comes to the well-being of children, and especially also their caregivers, because we've been also I think mentioning numerous times that children's well-being also really depends on their caregivers' well-being. So given that fact, what is one structural thing that could be changed within most systems that will significantly impact the mental health of parents and especially not only parents but caregivers, especially in crisis settings, for the better? And what will be one structural change that countries could implement in order to support their mental health?
I think across this research, pandemic and non-pandemic work, one consistent finding is that the healthcare system, but particularly in crisis-affected or under-resourced settings, are overwhelmingly designed to manage risk and to treat illness and to prioritize survival, but they overlook the emotional, relational, or embodied aspects of caregiving, which are so important for all of us, regardless of where we live and the context or the conditions in which we live, and that are crucial to early childhood development. So one of the most systemic changes, in my view, needs to try and understand how the psychosocial support and the medical care can be integrated in this context to care for families and support parents who might be going through fear, grief, uncertainty, and still need to provide care for their babies. So looking at how presence, connection, and continuity can be maintained will also be culturally responsive to the content.
I think there's a similar issue with mental health and psychosocial support, where even though the psychosocial is in there, and people are delivering those types of interventions, it can easily become about kind of diagnostic mental health outcomes. So only taking things seriously when it's anxiety and depression and PTSD, and the kind of evidence going in that direction, and forgetting about the kind of other kind of relational outcomes, as Rosa says, about kind of the coping and other, the quality of the relationships between people and how you feel. So I think you can, and sometimes that's in response to the crisis, right, Rosa? It's kind of like, okay, what should we this is what we can do, and this is more concrete, so it feels more, I don't know what the right word is, but kind of easier to access, maybe. I don't know. I don't know, too kind.
Make it much more accessible and easy to right? Yeah. So my pre-last question is mostly around the observations you made when it comes to the actual situation on the ground and the policy and academic research that is being conducted around nurturing care for children in emergencies, and also the family-centered neonatal care in emergencies. What were some observations you made that there were significant gaps in these areas, and what do you think is much more now urgent to explore more about to fill in these gaps? I mean,
probably it follows on from the previous point for me. Definitely understanding how systems enable or constrain nurturing care and nurturing practices for very sick babies in under-resourced settings or in crisis-affected contexts. Because we still know far too little about the system-level conditions that allow for nurturing responsive care to happen in hospitals, and especially for families who face the structural barriers like poverty, displacement, distance from hospitals. And the gap for me is in understanding that the policymakers are really constrained as well, and how to come up with these policies where in the political times or economic times that we are living with, what we as researchers are finding that is needed in the context, or the families are telling us that they need in the context. But definitely more research that captures caregivers' experiences across time and space and beyond hospitals, neonatal unit, and that highlight the kinds of policies or the infrastructure or relationships that make care, like relational care, possible, and recognizing that emotional care is essential. It's not auxiliary. It's not an added on or if we can, we do it. No, it is essential to the care of babies, in my view. And the culturally grounded, community-based models of family support that are needed in the different contexts.
Rosa, if I might just follow up very quickly, do you have an example of a good model when it comes to, or an example of community-based models that work well when it comes to providing mental health support for caregivers and children in emergencies?
So something that comes to my mind and is quite well known is the skin-to-skin care or kangaroo care model, which is widely known in the world and which was started in Colombia as part of the scarcity of resources. So because of the lack of incubators to care for babies started to be placed on the mother's chest. And there is a lot of evidence now about the benefits of keeping mothers and babies together. And again, it's not only the emotional connection and the well-being at a physiological level, so breathing improved, temperature improved for the baby. And that I think that's a community-based. It started because of the lack of resources and how creative the people in the community and in the hospital were, which we now understand how important it is. However, it is still not implemented in every country. So that's where we need to understand how to make it more available for the different communities in different settings.
Yeah, I would say one of the biggest gaps, again, looking at the primary research, is kind of thinking about, so looking at how people navigate their mental health and how they support themselves, almost outside of services, but prior to kind of primary mental health care. And so then looking at how the community does support itself through different crisis-affected scenarios. And then also thinking about kind of the sort of researching younger children. When any research that I do on children and young people is they're in mental health, they're often older. It's that verbal part when they're old enough, or is it okay to intervene? And so they have to be a little bit older. So I think one of the biggest gaps is kind of really looking at that kind of younger children's experiences in the context of families. And there is likely to be descriptive evidence or anecdotal evidence of that. But I think that when we're doing systematic reviews, we're looking for that primary research. So I think really kind of high quality research in that way can sometimes be missing. Yeah.
My very last question is more about what aspects of within the spectrum are you now focusing on, or are you about to focus on in your future research work? And if more people need to, of course, understand about this field and, if possible, also research about this field. So where do you see much more need to take a deeper look into the actual things when it comes to providing mental health support for caregivers and children in crisis settings? And what excites you currently about your field, where it's going, and what is it very much more to do?
I think from my perspective, it might be the mechanisms to implement and scale up some of these practices. So your previous question, which was an example of good practice, a program that is working, I think we need to identify them much more. I think they exist, but we not always know about them. And maybe particularly in the global south, where there's less research about these projects that work well at community level. So in my view, we need to understand them. So that's, for us, that's the next step in Mexico, is we are talking to policymakers and to some high-level officials, trying to understand, one, what projects exist. So we're also talking to clinicians and community members. Two, who has the power to do something about it. Three, how do the people with power connect to each other? What conversations need to take place for changes to happen? And what mechanisms need to be implemented so that they can be scaled up at a more population level?
Yeah, so building on Rosa, I'm always waiting for the primary research so that I can look at a few studies in an area that's looking at similar interventions. So I'm really excited to think about, primary research building up in this area of nurturing care practices for, very young babies, and then being able to look at the mechanism, so the theory of change behind those interventions, what is actually leading to making it work. So that's one strand. And then the other strand that I'm very interested in is the relational skills that we need for collaboration, and how we do research aligns with our values of the type of research that we're doing. So that's kind of like my methodological strand. Yeah.
It was really helpful for us to get to know what you are working on, how the field in general works in an international spectrum, and also what there's much more to do looking ahead. So thank you so much for your time and for sharing your insights. As we've heard today, prioritizing mental health of children and their families in emergencies is essential, not as an afterthought, but as a core part of long-term systemic solutions. A huge thank you to our guests, Dr. Kelly Dickson and Dr. Rosa Mendizabal-Espinosa, for sharing their work and reflections. Stay tuned for our next episode as we'll continue exploring key research insights shaping early childhood development in emergency contexts through our Early Evidence series.